All right, any questions from the first half? All right, so we're going to move into changing gears quite dramatically to HIV, STDs, and hepatitis. So all the fun stuff you get for being naughty, I guess. Not always, however. Sometimes you got to pay the piper, right? So we're going to look at some ways to treat that, though. So what is HIV? You guys cover this at all yet? Okay, what is HIV? Good, so it's a human immunodeficiency virus. What does that mean? Your body's not really attacking itself, not an autoimmune condition.
Oh, attacking a good cell. Something's happening with the good stuff, right?
So let's look at it. Let's see what's going on here. Okay, so right, so it's an infection, right, caused by the HIV virus. It's a retrovirus. What does retrovirus mean? It means it's injecting its own DNA, its own code into your DNA, and then you start to produce the virus for it, right? So it's turning you into a human virus machine, basically, right? So how's it primarily transmitted, though? Sexual contact, right? What else? Needle sticks, right? So you think about especially high-risk groups being IV drug abusers who are sharing needles. That's why you see like a lot of the clean needle programs that are being initiated to try to help prevent spread of communicable diseases like HIV, right? Certainly blood transfusions used to be a bigger deal than it is nowadays. You can have certain prenatal or perinatal transmission that can happen. Those are the most common ones you're going to run into. But basically, we are depleting the patient's own immune system, right? So this is what leads to that acquired what leads to eventually the AIDS defining illnesses, which is basically going to be this, any kind of disease that is based off this immunosuppression that happens over the long run. So we'll talk about AIDS defining illnesses. These could be things like PCP, pneumonia. It can include things like cytomegalovirus. It can include Kaposi sarcoma. These are things that manifest due to the fact that you've had this virus, you have HIV, and then you'd eventually are so immunosuppressed that you will develop these other conditions, right? Basically, what we're going to find is it's going to be targeting cells that are expressing CD4 receptors. So that's why the monitoring that we do. What do we monitor for? CD4 count and also viral load. We're also going to be measuring viral load as well when we're monitoring these patients. But basically, these are like T helper cells, lymphocytes, monocytes. These all get affected here. And this is where you can develop things like toxoplasmosis, PCP, pneumonia. We'll talk about those a little bit later. However, the mainstay of therapy, is there a whole lot of good non-pharmacologic therapy for these patients? No, you got drugs, right? So we're going to use highly active antiretroviral therapy. This is what heart therapy stands for. If you ever see that, this is what it's for. Basically, the life cycle we see with these patients is that you're going to have, and this kind of shows you where a lot of the different drugs you're going to be working at. You will have the virus that will come into the cell, and again, it will be those that have the CD4 receptor being expressed here. It will get in, it will incorporate its RNA into our DNA. Once it's integrated, then it will be able to start to produce, your cells will start to produce HIV virus. And then we'll then release that and then go on and infect other cells, right? One of the big things you'll note with the HIV virus is that it is very difficult to, how come we don't have a vaccine against it? Mutates all the time. It's a very sloppy virus. It'd be nice if it was very regimented and we always produce the same sort of viral proteins. However, it changes all the time. This is where a lot of resistance comes from, and this is why we can't have things like a vaccine against it, at least currently, that targets that, because it's a very, very sloppy sort of virus. So basically, it's necessary to understand where the different drugs are going to be working at based on their targets. And so, again, once we have the virus that will enter the body via this glycoprotein 160. Basically, it has an affinity for the CD4 receptor. So once it kind of finds a cell, the virus finds a cell that has that CD4 receptor, it'll bind to it and will allow for that initial translocation to occur. You're also going to find there's a CCR5 protein that some cells will express. Not everyone expresses this, but some do. And this is going to be a site for a specific drug that's going to work. And this will be something that facilitates the virus actually getting in and working more effectively. Once it's going to bound, once it's bound, the virus will get internalized into the cell, and then you're going to see that it uncoats itself into the single-strand RNA. The RNA will then use an enzyme called reverse transcriptase. It's going to be an important enzyme we're going to be inhibiting with our drugs, and that will make a complementary strain of DNA. It's the retrovirus, and then that will end up getting lots of mistakes happen at this point, right? So the retrovirus or the reverse transcriptase is going to be very sloppy. It's going to make a lot of mutations. Again, this is where I see a lot of resistance comes from this. But basically, once that happens, it can then utilize that reverse transcriptase to form a double-stranded DNA, and then that can migrate to the nuclease. It'll get integrated into the host DNA via an enzyme called integrase which kind of makes sense. Integrates the DNA into the host, and that'll be another site for drugs to work here. And then we'll start to make a new viral RNA and proteins and all of that. The virus can then kind of encapsulate itself, bud out the cell, and then go and attack something else, right? So again, wash, rinse, repeat. This is where you kind of have this overwhelming immunosuppression, because eventually your CD4 cells are just dedicated just to making viral proteins, not really to being very effective at doing their job, right? And they eventually get depleted. Eventually, you're going to find that immunosuppression will kind of take over, and then that'll be that. Because again, what often kills these patients? Opportunistic infection. That's the thing that kills. The HIV is not what kills the patients, not the AIDS necessarily. It's the AIDS-defining illnesses they develop is what kills them off. And, however, nowadays we're going to find there's actually other things that will kill them off, because we have a lot better therapy and they're living for a lot longer. So now we have things like heart disease and diabetes and things like that they're having to deal with. But anyway, big thing here is that there's kind of 3 main phases of infection. Is it very easy to catch HIV super early on? No, a lot of people end up having it for quite a while before they actually really notice it. So they'll have this kind of acute phase, this kind of acute retroviral syndrome that happens. It kind of feels like the flu. They may not really know what's going on. They just feel like they're sick. And then there's kind of this latent period where they're going to be asymptomatic for a good long period of time. The virus is replicating, sitting there, but the patient doesn't have any manifestations of illness because they still have a decent white count, right? They still have a decent CD4 count that's working effectively at blocking infection. Then eventually they're going to get this chronic stage where they're diagnosed. They'll be on heart therapy for a while, but eventually they can develop AIDS defining illnesses, right? So I mentioned PCP, pneumonia, Kaposi sarcoma, etc. And the main monitoring we're doing is going to be for CD4 cell count and viral load. Those are the 2 main things we're monitoring for. Viral load shows us the more viruses around. What do you think that means? The more can go and infect other cells, right? So it shows you there's a lot of viral activity. There's a lot of viruses being made. That's a bad sign. You want low levels of virus, right, to be detectable in the blood. How about the CD4 count? What do you think that tells us? It tells us how good the immune system is, right? If you have no CD4 cells, guess what? You're probably going to get sick, right? If you have a high CD4 count, it's going to be better for us. So again, those are 2 things to monitor for. One tells us how good the immune system is. The other one tells us how fast the virus is replicating. So our main goals here, want to decrease morbidity and mortality. And like I said, back in the day, if you have watched any documentaries about the HIV epidemic in the 80s, it's really kind of amazing how far we've come in just a 30-year period as far as the medications that we have and how much longer these patients are living. Because again, if you got AIDS back in the 80s, chances are you're probably not alive today in a lot of cases. However, we've got a lot better therapy. They're living for much longer. They're now starting to die of other complications of just getting older and these metabolic complications. So we'll look at some of the drugs and how they can kind of influence that, but the main thing is that we're trying to preserve their immune function as long as we can, prevent these infections from occurring, and keeping them living as long as possible. Okay. Our main goal is to get undetectable viral loads, right? We want to have no virus we can detect in the blood, and when our CD4 count's high as we can get it. Not like leukemia high, but we want to get as high as within a somewhat normal range, okay? So what we're going to do is we're going to try to prevent that retroviral replication, right? We're going to get look at that plasma HIV RNA level to see kind of what the load is going to be. We want that to be as low as possible. Otherwise, that indicates that the virus is replicating at a high level. And then again, that CD4 count tells us the extent of the immune damage here. So our goal when we're giving highly active antiretroviral therapy, we want to have a good CD4 count. We want low, undetectable, really should be undetectable viral loads for those patients, okay? What we're going to do for that is we're going to give them at least 3 different agents. So this is important to understand, like, what are the components of the heart therapy. It's going to be at least 3 drugs, okay? It's going to give you the best chance to get a good viral suppression, and it's going to allow you to keep that CD4 count up as long as you can, okay? And so you're going to find that once you start to develop resistance, it can be very difficult because, again, once you kind of there's some degrees of resistance that can be, drug category wide. So, for instance, if you have one mutation that makes you resistant towards one drug, it may mean you have resistance against other drugs in that same category, right? So there's going to be things to consider, because then once you start to lose out on a lot of those categories, you may not really have a whole lot else to treat them with. So we'll look at some examples of that as we go forward. So again, you want to keep resistance down to as minimal as possible. The biggest thing that can help with resistance is to make sure they're taking their regimens like they're supposed to. If you're non-compliant with their regimens, if they're not taking like they're supposed to, and they're only taking, say, 2 drugs instead of 3, what can happen? Resistance, right? Just like if you don't take a full course of antibiotics, what can happen? Resistant bacteria. Same thing happens here. Okay, so compliance is super, super important. And if you imagine, like, high-risk patients who have HIV, think about IV drug abusers. How likely are they to be compliant with their medications? Not great, right? So again, depending on what their home situation is, if they have a home, depending on what their life is like, they may not have the greatest compliance with that. So this is another key point for education, why these programs can be so important. And prevention is key, right? Try to prevent it in the first place. So when should we start therapy? And again, this has only been around for, say, 30 some odd years. Like, we're still trying to figure out a lot of this stuff. And what we've come to determine, and for a while it was like, well, you don't treat HIV until the CD4 count gets so low, right? Nowadays we said, well, we need to just go ahead and try to treat as early as we can, try to preserve that immune function as long as we can. So nowadays we actually, as soon as they have a diagnosis, we'll go ahead and start therapy immediately, right? So this is going to be regardless of CD4 count. Some recommendations will still be based on CD4 count. So for instance, when we're doing prophylaxis for certain opportunistic infections, that will be based on CD4 count. So those would be things you want to look at. And again, are you guys going to necessarily be treating, are you guys going to be writing these regimens for HIV therapy for these patients? Not necessarily, not unless you're working specifically in that sort of setting. However, your patients may be on these drugs. You may see a lot of patients who are on these. You need to be at least familiar with them, right? Side effects, other metabolic effects, you can see things like that, okay? Just like cancer, you may not be treating cancer, but you may see a lot of patients who are on cancer treatment, okay? All right. So the main classes of drugs we're going to look at, we're going to have our integrase inhibitors. So again, this will prevent integrating the viral DNA into our DNA. We're going to have our nucleoside reverse transcriptase inhibitors. So again, these are working on reverse transcriptase, specifically to inhibit that. We're going to look at non-nucleoside reverse transcriptase inhibitors. Okay. We're going to have our protease inhibitors. Then we're going to have some kind of newer agents like entry fusion inhibitors and a co-receptor inhibitor. Okay. And again, if you do this, took the same class, 5 years from now, there's probably going to be even more new drugs that are out there, but this is kind of a current listing that we have right now. We'll talk about what the most common things to start out patients are on, and talk about some things you can kind of move on to as backups. So starting out, we're going to kind of go with the big three classes that we use for most of our regimens here. So we're going to look at our nucleoside reverse transcriptase inhibitors. Basically what this means is they're based off of, you kind of think back to when we talk about cancer, we talked about the anti-metabolites, we talked about drugs that kind of masquerade as normal base pairs to get incorporated into the DNA, and once they do that, then they stop the chain elongation, right? Because it's different enough where DNA polymerase couldn't do anything with it. We're kind of doing the same thing here with these. And so we're going to have things that are thymidine analogs, deoxycytidine analogs. It's not important to necessarily know which base that it's trying to mimic as, but basically just know that these are going to get incorporated into that DNA, and then once that's done, it can't really kind of continue the chain any further, right? Be aware of just what class these drugs fall into, and again, most of them are going to end in things like vir, so you can't always use that to know that it's specifically for HIV, because like acyclovir is for what type of virus? Herpes, yeah, primarily herpes. So again, you're just going to have to kind of look at these and just kind of get used to seeing them and being able to kind of categorize them to which category they fall into. Note here, just like with chemotherapy, HIV people love their abbreviations. They love to do things like stavudines, D4T. It goes back to the actual chemical name of the drug. However, it is very error prone, and I hate when they use these abbreviations. However, it's something you're going to see pretty frequently. Like zidovudine or AZT, that was one of the very first drugs we had for HIV, and it was kind of the only drug we had around for quite some time. But just know there's abbreviations that are out there. I'm just going to only put the brand name in the generic, so I just put the abbreviations here just for reference, right? Just so you can kind of get familiar with seeing them. So again, basically these are going to get triphosphorylated, right? So we're going to get 3 phosphates added onto there, and then they'll basically be competing with the endogenous nucleotides for those same catalytic sites, right? So basically by preventing that elongation, you kind of see this where you have reverse transcriptase, and you have the viral RNA here. We're producing DNA, but once these get stuck on here, they're chain terminators. They can't really elongate that DNA any further because they basically are different enough to where there's really nothing to attach onto. Okay, so very similar to the antimetabolites we looked at, very similar to other sort of viral antiviral drugs like acyclovir does something very similar to this, where it basically caps off the end of that DNA and you can't add anything onto it. And once it's kind of inactive, then you can't really produce any new virus from that. Okay, that's how those ones are working specifically. Now again, adverse effects are typically going to be affected or mediated by some of the actions on, and again, we would love if everything was very specific for the virus. However, there's going to be a little bit of bleed over. So you may see some mitochondrial effects on DNA and RNA. And so you're going to see these are going to be more often going to be pronounced with things like stavudine, didanosine, and zidovudine. However, a lot of the newer ones we have lack a lot of these side effects. But the things you could see would be things like peripheral neuropathies, pancreatitis, anemia, lactic acidosis with a fatty liver. These are kind of things you would see with a lot of the older agents. Nowadays, some of the newer ones, things like abacavir, tenofovir, these are ones I highlighted here, probably more likely to ask on the test just because they're going to see these used more frequently as kind of first-line agents in a lot of cases. They mitigate a lot of these side effects. The only thing you want to be careful of is with abacavir, you have to test for this particular the genetic mutation. If they have an HLA B5701, if they have that, then they're going to be much more likely to have anaphylaxis to abacavir, and they cannot receive it. So that would be one case where we're actually doing genetic testing prior to giving this drug. So again, it's probably one they kind of move to as a second line, if anything, because of the fact that you do have to do that additional testing for it. Okay, so the next group we'll look at are going to be the non-nucleoside reverse transcriptase inhibitors. So basically, this is working similarly on reverse transcriptase. However, it's going to be working differently. Then it's not going to actually be incorporated into that DNA strand. What it's going to do is actually going to bind next to a catalytic site, and it'll actually change its conformation. So basically, it's going to not be able to interact with the viral RNA anymore, right? So again, this is kind of, again, this is simplifying it, but when it's in the circular shape, it can interact with viral RNA. That's kind of in a more closed-off shape. It can't interact with it, okay? So again, different site of action, but the end result's the same. Reverse transcriptase is being inhibited. This one's just working on the actual enzyme itself versus getting incorporated into the DNA. That makes sense? Okay, so again, this is going to be the second leg of our three-legged stool of heart therapy, right? So again, this is the second component we're going to see in a lot of these regimens. So we have non-nucleoside reverse transcriptase inhibitors. We're going to have a non-nucleoside reverse transcriptase inhibitor, right? So we have one or the other, and we'll look at our the third component here just a little bit. Okay, so components here usually dolaverdine, efavirenz, nevirapine, etravirine, and rilpivirine. I'm starting to see these two being used more frequently as kind of your first line ones. Pretty well tolerated for the most part. Maybe see a little bit of transaminitis, a little bit of rash, but for the most part they get very well tolerated. Now, the one thing you note here is that you can't utilize these drugs forever because one thing you can see is that a viral mutation can actually confer resistance across the whole group. Everything except for etravirine. This one can maintain some activity, but if I was on, say, efavirenz and I developed mutation against that, then I couldn't use dolaverdine. I couldn't use nevirapine because, again, the whole class would end up losing efficacy, essentially. The only one that's an exception is etravirine, which is why you're seeing this one being used much more frequently nowadays. Okay. All right, the next group, the main kind of the third main group of drugs you're going to see used in heart therapy is going to be these protease inhibitors. And so these are basically going to be working directly to inhibit that protease enzyme. Basically, it just prevents a virus from actually making mature protein. So it doesn't really work on reverse transcriptase, but it's working on the protease that would normally take this kind of uncut polypeptide chain made from that DNA and prevent it from being kind of broken into its component parts, right? So it just kind of stays all stuck together, can't really do anything at that point, right? So you prevent mature viruses, mature proteins from being made for that. So pretty big list here. We're going to see we have things like atazanavir, darunavir, fosamprenavir, indinavir, lopinavir. Usually you're going to see lopinavir in combination with a drug called ritonavir, which we'll talk about in a second. It's called Kaletra. If you ever hear Kaletra, that's what that's referring to as a combination. And the thing you'll see with a lot of these drugs is we're focusing on combination therapies. Because if you ever watch like any old videos of someone who's on, you look at like 90s videos of an HIV patient, they would have like dozens of pills they're taking a day. Nowadays we're trying to really condense that down because fewer pills means what? Better compliance, right? So better compliance is the thing we're shooting at. Nowadays we have drugs that you can just take one pill a day for most patients, right? So again, we're going to look at the example of that in just a little bit. But again, simpler regimens can be better off for our patients. So anyway, next we have nilfinavir, ritonavir. Now, ritonavir is going to be kind of the oddball out of this group, and I'll talk about why that is in a second. But then you'll have sequinavir and tipranavir. Those are the main ones we have here. Ritonavir is really kind of interesting because it's a very potent 3A4 inhibitor. Okay, so it's going to be inhibiting CYP3A4. The reason why that's an actual benefit here and not necessarily a problem is because it can actually work as a booster for other protease inhibitors. So basically, when I mix it with lopinavir here in this example called Kaletra, by blocking CYP3A4, I can lead to much higher levels of lopinavir. The higher levels means it's going to have more activity against the virus. Okay, so oftentimes you're going to see two protease inhibitors together, one of which will be ritonavir plus something else, and that's being used as a booster in that case, right? It's not a therapeutic duplication; it's meant to be utilized in that pharmacokinetic interaction. So kind of using interactions to our benefit, or our patient's benefit. So a lot of side effects associated with the protease inhibitors, though. Most of them are going to be metabolic. So certainly GI distress, but you can see increased lipids, hyperlipidemia associated with this, glucose intolerance. So again, this wasn't a problem back when patients were only living a couple of years with HIV, but now, or with AIDS. Nowadays that they're living much longer, they're starting to see the ramifications of these metabolic conditions. So starting to see more diabetes, starting to see more heart disease associated with that. And again, they're not necessarily dying of AIDS, they're usually dying of something else in some cases. Other things you can see, you can have this altered fat distribution or this lipodystrophy that occurs here. So you know this kind of buffalo hump that happens. That if you ever see that, it's probably someone who's been on protease inhibitors for a very long time. So for several years, they get that lipodystrophy there. So again, most of these are going to be metabolized in the liver, but again, by giving low-dose ritonavir, or there's actually another drug called cobikistat, and we'll look at a few combination drugs a little bit later. These are going to be important 3A4 inhibitors that lead to higher drug levels and lead to less frequent dosing. So again, instead of having to give Kalitrase 3 times a day, maybe we'll give it 2 times a day or 1 time a day in some cases. So again, but you have to watch out for other drug interactions, right? So again, if they're on a statin or they're hyperlipidemia, guess what? You got to watch out for that interaction there. Put them on something that's not metabolized by 3A4 or something like, you know, Lipitor or rosuvastatin or something like that, right? Okay, next group we'll talk about are going to be the fusion inhibitors. So these actually prevent the fusion of HIV-1 kind of working to incorporate itself into the actual cell, right? And what's interesting, these only work for HIV-1, not for HIV-2. Anyone know where you find HIV-2 predominantly? Usually like in African countries. So you kind of think about the distribution mainly here in the US is HIV-1. Over in Africa, you normally find a lot more HIV-2 and kind of other areas around there. So I'm not sure about Europe specifically. I'd imagine it's probably more of a mix if I had to guess. But again, I don't deal with this every day, so who knows? I just know that a lot of those countries, African countries, will find a lot of HIV-2. Over here, it's predominantly HIV-1. So this is why we can use a fusion inhibitor here that works on HIV-1 specifically, but you may not use it if you're over in the African continent, right? Anywho, so this is a peptide. So again, it's a protein, so we know we can't take it orally. All these other agents we've looked at have been oral so far. But this one has to be given subcutaneously. And so basically it's going to prevent that fusion of the actual HIV virus from interacting with the cell and kind of incorporating itself in there, right? So prevent that kind of endocytosis sort of effect that happens there. We'll see some pain at the injection site, some nodules that can form there, but otherwise pretty well tolerated for the most part. Next, we have a CCR5 antagonist, and I'll show you which one of these we're using most frequently, which ones are kind of going to be add-on sort of therapy. But next, we have the CCR5 antagonist. We mentioned CCR5 is a protein that's meant to facilitate HIV getting into the cell more effectively. Not everyone expresses this, and so this is another drug where you have to do a test beforehand to see if they actually express it or not. So work on both HIV-1 and 2, but basically it's going to block the human receptor. It actually doesn't work on the virus itself. So that's another kind of unique thing about the drug is it doesn't actually work on you know, a specific viral enzyme or protein. It works on the human receptor. And so what you're going to find is that if they do not express the CCR5, cannot use it for them, right? Or actually what you're actually testing for, I'm sorry, I should say, is that the virus, if it has that co-receptor available, if it has the ability to bind to CCR5, then that will work. If it doesn't, then it's not going to be able to be that effective. And you'll find eventual mutations where they'll actually lose the need to bind to CCR5, and this drug will lose efficacy over time. Okay, you can't use it forever for some of these patients due to mutations. Okay. And then I think one of the last groups we'll have here is the integrase inhibitors. This is probably the newest group that we have out of the bunch. We have things like raltegravir, dolutegravir, and then elotegravir. And so these are going to be, this one specifically is formulated with cobikistat. Again, that's just a 3A4 inhibitor. Has no antiviral activity on its own, but will block 3A4 to increase those levels, so we give the drug less frequently. Basically, it binds to that integrase enzyme, prevents the DNA from being incorporated into our DNA. And again, if it doesn't have that incorporation, that CD4 cell can still act kind of normally. Very well tolerated for the most part. Again, you know, a little rash, nausea, headache, but being a newer class, we don't have as much, you know, a few decades of use with them yet. So again, we may still find side effects that come up, you know, down the road. Okay, so again, some of the drug interactions we see with this are going to be on purpose, especially with ritonavir, especially that cobikistat or the rising levels of the drug by blocking 3A4. However, you need to watch out for other drugs being affected by this, right? So for instance, you know, favirenz, etravirine, nevirapine, they will induce CYP3A4. So they may actually lead to your PIs being less effective, right? You're going to find most protease inhibitors do inhibit 3A4 to some degree, so you need to monitor their other medication regimen to see what can be affected. If they're on verapamil or diltiazem, that can be affected. Lots of drugs, again, are affected by 3A4. The other thing to consider is the other interactions with things like, you know, drugs used for There are opportunistic infections like tuberculosis. We use rifampin. Anyone remember what rifampin does?
Adverse effect.
Yeah, what does it do to 3A4? Actually induces 3A4, right? So that could actually lead to lower levels of your protease inhibitors and lead them to be less effective, right? All of a sudden you're treating your patient for TB and it comes back and their viral load starts to rise and they're taking their drug like they're supposed to. It could be related back to the 3A4 levels not being high enough or being induced there. So things to monitor for. Look for food-drug interactions. Some drugs are going to require an acidic environment to take. So if you're giving them a PPI or an H2 blocker that may interact with it, these are things you're going to look up. And again, if you work with these patients day in and day out, you're going to know these interactions by heart, right? But again, I'm not going to go through and list every single one of them out there. So when in doubt, look it up, okay? Especially if you have a patient comes into the ER, they're urgent care, they're on therapy for HIV, make sure you get a good medication history, get a good list, so that way if you're going to prescribe something new, make sure it's not going to interact with their drugs and cause any issues there, okay? All right, so treatment is very much an evolving process. Guidelines change pretty frequently as we're starting to see new trends in resistance and things like that. So again, look up the current guidelines. A year from now, this may not be current anymore. So again, it's going to be one of the things that changes. What we do know is that typically what you're going to find is you're going to have 3 drugs. They're going to be the backbone of your heart therapy, okay? The primary thing we're going to be recommending first is going to be a minimum of some sort of protease inhibitor or a non-nucleoside reverse transcriptase inhibitor, an NNRTI, plus 2 NRTIs. Okay. Generally, your backbone is always going to be 2 NRTIs plus one other classification drug, right? For example, and they'll have, if you look in the guidelines, they will have recommended regimens, like recommended initial regimens, and then if you can't utilize that for allergies or whatever reason, they will have backups there. Okay, so for instance, and notice these are all initial regimens. What do you think is going to determine what we're going to use for, like, say, follow-up regimens? How well it works can be one thing, but what are we going to do specifically to see how well those drugs are working? So you're monitoring that, but also what can you do with the virus? What do you do with bacteria to see if antibiotics don't work?
Culture for bacteria, it's like a PCR.
Yeah, so you end up doing resistance testing with us. We'll talk about resistance testing a little bit later, right? So again, yes, you're monitoring certainly a baseline efficacy by looking at viral load, which should be undetectable, and CD4 count. But the other thing you can do is to see specifically which drugs may work or may not work. You're going to do resistance testing. We'll talk about that in a second here. But initial regimens usually something like a protease inhibitor plus 2 NRTI. So for example, we could do darunavir. It's being boosted by ritonavir, right? So now we have a 4th drug we're adding on here, plus tenofovir and emtricitabine. I'll show you some examples of drugs, combination drugs that come available, so that way they can kind of decrease that kind of pill burden the patient's having to take. And again, I might ask a question: do you need to be able to recognize specifically which category these drugs fall into? Because I may ask which one of these would be an appropriate regimen, right? So I may put like 3 NRTIs. I may put 3 protease inhibitors. You know those are all wrong, right? You would know that you're looking for at least 2 NRTIs and one other drug, like a protease inhibitor or an NNRTI. Okay. Those would be things I might ask questions on. Now, because of the fact that the NNRTIs, once you develop resistance to one of those, you end up losing most of the class, not as recommended anymore. So you can do something like efavirenz plus tenofovir plus emtricitabine. You notice here that the 2 NRTI backbone, tenofovir and emtricitabine, are the most commonly recommended ones nowadays. You may also do something like an integrase inhibitor plus the 2 NRTIs, like raltegravir plus tenofovir and emtricitabine, right? So again, these are kind of the common ones that are most frequently recommended right now. May change, a year or 2 down the road. So again, variable adherence is super common, and again, the more variable the adherence, the more likely resistance is going to pop up here, and determine ultimately how successful you're going to be in treating these patients. So reasons for poor adherence: they have concomitant psychiatric illnesses, they have substance abuse problems, adverse effects. They may say the adverse effects are too much, I'm just going to get rid of these. Some of these cause really severe diarrhea. I remember when I was in school, we had a class called Pharmacotherapy, where basically we'd have kind of a patient scenario. We'd have to do the interview, and and then we'd have to write a case up basically with a soap note. Essentially, we had a guy that came in who actually had HIV. He'd gotten it back like in the early 90s when he had it. And so actually talking to somebody who had dealt with this, who had lived through, all these new drugs coming out, and be like, oh yeah, this one's terrible, because, I had to like basically bring an extra set of pants with me because I might have diarrhea so bad that I just, wouldn't be able to make it to the bathroom. So therapy's gotten better. It's not perfect, but again, adverse effects may be a big reason why they're not going to be compliant. So you need to assess for that. And especially if they have unstable social circumstances, if they don't have a place to live, they don't have good access to medical care, this could be another big determinant there. Okay, So typically, whenever possible, use formulation therapies. This helps to limit the number of pills they're taking. And again, it can also limit some of the food restrictions you're going to run into, so watch for those. And so, for example, we now have something like efavirenz, emtricitabine, and tenofovir. It's a drug called Atripla. It's got the tri in there, it's 3 drugs in one. That is a good one that a lot of patients get started on because, again, it's a 1 pill they're taking, I believe, just once a day. You have to double check me on that. But again, therapy used to be dozens of pills a day they have to take to get these regimens, and now we have just 1 pill they can take potentially. Another one, they have eltegravir plus this cobicostat, which we know is a 3/4 inhibitor, plus emtricitabine, tenofovir, again, Voya. Another one, emtricitabine plus rilpiravir, and tenofovir, Complera. So again, there are options that are out there to really reduce that pill burden, and this is only going to be beneficial. The only question is, who's going to pay for it, right? So again, these can be pretty expensive. They have good insurance. This can be very useful for them. Okay, so resistance testing. So we need to do this to make sure the drugs we're going to prescribe are actually going to be effective for them. So there's 2 different types. There's going to be phenotype testing, and there's going to be genotype testing. Okay, so what do you think is the difference between these 2? So one's looking at specifically just the genotype. So one's looking at the actual genetic code of the virus to see, okay, well, based on these changes, we know that if it has this mutation, it likely confers resistance to this drug, right? So again, it's a little bit more abstract. It's a lot easier to do because you're just looking at the code of the virus and saying, okay, well, we think it's going to be resistant to this, but susceptible to this, and this. Okay, limited information. The phenotype testing, this is going to be more likely or more similar to if you were doing an actual culture sensitivity on a bacteria, where you'd actually plate it out and you would actually put in discs of different antibiotics to see how it responds to it. This is where you'll actually be able to look at the actual inhibitory concentration, the IC50. It's very similar to that minimum inhibitory concentration for bacteria, right? Remember that? It's very similar to that, where we can actually do real-world testing to determine what actual resistances it has. So again, more informative, higher costs, longer turnaround times. That's kind of the negative there. So for most patients, you'll start out with an initial therapy recommended by the guidelines, and then based on resistance testing, you'll determine what to follow up with in case they fail that, right? So again, they can go years on an initial regimen, and then eventually once it starts to lose effect, CD4 count goes down, viral load levels go up. That's when you need to look into testing to see if you can switch it out. Okay, because again, if you're depending, who determines how resistant of a virus you get if it's your initial diagnosis. Well, whoever you got it from, right? So if they had a really resistant form of the virus, and that's who you got it from, guess what? It doesn't just go back down to the wild type virus. It goes back to whatever they gave you essentially. So again, this concern is how resistant was it when you initially got it. This is why you see this kind of evolution of what drugs are being recommended, and will change over time depending on resistance patterns. So again, one other thing to consider is HIV and pregnancy. Generally, you're going to treat those patients as if they were not pregnant, because again, if the mom succumbs to illness, the fetus does not do much better. And so basically what we're going to do is try to maximize that viral suppression, because that will actually limit the exposure that the fetus has to the virus. So if you can get that undetectable, it means less likely the fetus is going to pick it up in the perinatal period. One drug we do avoid is efavirenz, because that actually leads to neural tube defects, similar to something like valproic acid. So we don't use that one. And then what they'll actually do for the intrapartum period, the kids being born, is they'll do zidovudine. So again, very limited regimen, just NNRTI in that case. But basically, they'll go ahead and give the fetus zidovudine for 4 to 6 weeks after birth, and that way that will hopefully suppress the virus enough where it can't really take hold, and hopefully the kid will come out HIV negative in the long run, right? So again, typically this is pretty effective for most cases, and again, they probably want to avoid breastfeeding at that point. That would just use formula or something to avoid any further exposure from the mom, right? Because it's not just blood you're having secretion of the virus, but it's also going to be mucous membranes, things like that. So any kind of fluid being expelled can be at risk for that. So breastfeeding is included. Okay, so chemoprophylaxis. So who might need prophylaxis for HIV? Partner, potentially. Because again, you can't choose who you love, right? Unfortunately.
Sure.
Depends, I guess. Healthcare exposure is the other big one. Yeah, it's a high risk exposure. Needle sticks. I remember the first time I had to, I had a family practice rotation when I first started out, and the first patient I had to do doing point of care INR testing. So I do use this little finger stick thing to test their INR. First guy I had was this guy, had below the knee amputation from diabetes, but had Hep C, HIV, and big old calloused hands. And I had to get blood out of him, and I was just like, I'm going to get squirted in the eye, I'm going to get HIV, I'm going to get Hep C, I'm going to get everything. It's ridiculous now in hindsight, but when you're first time dealing with actual patients in your life, you don't know any better. But right, so healthcare providers, post-exposure prophylaxis, these are things to consider, right? So this is good for healthcare workers, mainly after high-risk exposure. So again, if you don't know the status of the patient you got stuck with, guess what? You need to get post-exposure prophylaxis, right? But ideally, if you know, you get the patient tested, that's going to be most beneficial there. So again, you want to know the status if possible, and you want to start as early as possible. Obviously, after needle stick, what's the first thing you do? Not freak out. You don't freak out. Wash your hands, soap and water. The best thing you can do is wound care, right? So again, get the hands nice and clean, or wherever you got stuck. And then what they'll do potentially is a mixture. Basically, they'll put you on like kind of a full press sort of regimen for 4 weeks or so to make sure that any virus that did get into your system is inhibited pretty well. And again, by using an integrase inhibitor, prevents it from ever actually getting into the cells, hopefully. And you prevent any kind of hold from being taken by the HIV. Okay? Yes, ma'am. Okay. For pre-exposure prophylaxis, this may be for patients who have a serodiscordant couples. What does that mean? One person's positive, the other person's not, right? Or like high risk, because usually what you find is that receptive anal sex tends to be the most likely to contract HIV. So again, men who have sex with men, that is a high risk population. So they can potentially get daily Truvada, which is just a mix of 2 NRTIs. So again, if they're high risk, but they don't have the disease yet, this is something where they can potentially protect themselves. IV drug abusers obviously is a big thing there. Obviously, if you can focus on lifestyle modifications, like maybe don't do IV drugs, that would be most beneficial. But however, not always going to happen in most patients. And then you do need to test to make sure they're seronegative prior to initiation, because you don't want them to tell you that. You need to actually test them, because if they have it, if they are positive, they need to get the full regimen.
So let's say the healthcare worker nothing happened. Will the drugs make them like sick or unable to work or anything like that?
No, I mean they may have side effects. That's for sure. But again, it's only for 4 weeks. And again, if I had to consider like the risk of side effects for 4 weeks versus having HIV, like yeah. And again, it depends on, and this is where it's really important to contact. Depending where you're working at, there should be some sort of infection control person, ideally, especially like in a hospital. There's a whole department dedicated to that. Infectious disease providers, like they're good people to talk to be like, okay, here's the situation. Do you think I need post-exposure prophylaxis, right? Some people are very hesitant to, I worked with a lot of nurses who are very hesitant to start anything because they have, the breastfeeding their children, right? And things like that. So these are things you have to consider. Some people are very hesitant to start therapy if they don't really need to. So this is why you can try to have some kind of, risk evaluation by someone who's an expert, like an ID provider, right? Yes, ma'am.
So you mentioned like the people that are not going to be compliant. Do you not then treat them because of risking resistance, or do you go ahead and treat them?
That's going to be on a case-by-case basis. Ideally, you'd get them treated, but the thing could be, why are they not compliant? Is it because of side effects? Well, maybe I can change drug regimen, right? So I don't have to use a protease inhibitor containing regimen. I can use like an integrase inhibitor. Maybe that's enough to change the side effects where they could be more compliant. Is it because of cost? If I can find cost alternatives or some sort of program that can help them from a financial standpoint. More of a lifestyle. If they just like, if they don't really, they have kind of a laissez-faire attitude about it. That's where you kind of have to bring down the hammer a little bit. You use a little tough love to be like, listen, this is what can happen. You will die from this eventually. Like there is no, without treatment, HIV is 100% mortality rate essentially, because you will catch some sort of AIDS-defining illness. You will die from this, right? So having a little bit of that conversation there to make sure they understand the gravity of the situation, which I think when most people hear HIV, I think we've pretty well ingrained in society, like, yeah, this is a serious deal. But yeah, some people are still not going to be compliant. It just depends. I think talk to an ID provider. They might have a different, kind of guide on. They may have patients they've dealt with like that who are they decided not to treat, or they decided to just continue and only getting some effect. It's hard to say. Because again, what's the risk of them having HIV? If they're having like, especially really kind of high risk behaviors, if they develop a resistant bug and they give it to someone else, right? It's kind of one of the concerns you have with that sort of thing. So again, it's going to be on a patient by patient basis, but good question. Talk to an ID doc, they might have a lot more to say about it. And they have actually a whole ID pharmacist. Like, I actually took an elective for this when I was in school, and our teacher, that's all she did, was she's just an HIV pharmacist, and they can be a good kind of not a physician extender, but someone who can actually help out with interpreting a lot of these like resistance typing, can work and counsel the patients, and as far as like side effects, drug interactions, things like that. So there's lots of providers who can kind of help out with this whole process here. Anywho. Okay, so again, looking at our outcomes, we're going to be shooting for having undetectable viral RNA loads. We want to have high CD4 counts, and again, we typically will test for resistance at the beginning. Again, you start therapy regardless. You do one of the initial regimens, and then you're going to start up resistance testing at the same time, and then eventually you're going to monitor every 3 months or so until that viral RNA is undetectable. Okay. Now, reasons to switch drugs are going to be if they have intolerable side effects, if they have a treatment failure, so if they're getting more than 200 copies of the viral RNA per ml. Failure, right? You need to be undetectable, or if they have any kind of documented resistance. So, for instance, if I started them off on darunavir, tenofovir, and tricytidine, they showed back up with resistance for darunavir, I would switch them over to something else, right, at that point. So again, it's okay if they're on that regimen for a short period of time. Once the results come back, then you can switch them up. Okay. So, looking at complications of HIV/AIDS, so what can we do for these patients? So, opportunistic infections are, again, the major cause of mortality for a lot of these patients for a good long time. And we know that as you have declining CD4 counts, this is when you're going to start to see more of these opportunistic infections show up. And we actually can define, like, okay, if their CD4 counts less than 200, they're at risk for this. They're less than 50, they're at risk for this. And again, a lot of these things are not going to be illnesses that healthy individuals normally get, right? These are going to be things that we can normally fight off pretty easily. However, they have an altered immune system, right? So things like PCP pneumonia, things like cytomegalovirus, Mycobacterium avium complex. And so what we can do is once their CD4 count gets low enough, then we can start to initiate what we call prophylactic therapy for certain things. And then once they actually have the illness, then we'll start treatment therapy for those if and when they develop it. Okay. The other thing to consider, they may have latent infections that may reactivate. So for what's a good example, something like that. TB is a good one, right? So again, TB testing is important in those cases. So again, this list will not be all inclusive. Again, if you want good guidelines for this stuff, look up aidsinfo.nih.gov. Very good website to get all of your most up-to-date HIV information, especially if you have any kind of interest in working in this field. It's a very good site for that. So anywho, our goals is, one, we want to prevent any kind of exposure to opportunistic pathogens. So again, if you're never exposed to it, you're unlikely to get it. That's going to be one thing we can do. And then if we can vaccinate prior to illness, that's going to be great if we can do that for those patients. Because again, a lot of these patients, if you catch them early enough and you're treating them well, their CD4 counts will be high enough where they're not really having to be treated like an immunosuppressed patient like you would see like for cancer or something like that. Then we'll do chemoprophylaxis once they're under a certain CD4 threshold. And then if they develop the disease, we'll actually treat that. And then once they're kind of over that illness, then we'll put them back on prophylaxis until their CD4 count recovers enough to where they can come off of it, right? So this is kind of what we'll do for most patients for certain these opportunistic infections. So other considerations, again, if they're diagnosed, if they are, the first diagnosis of HIV is in addition to the opportunistic infection, right? Because you could have it for a long time and never really know it. There's going to be some benefits, obviously, to starting antiretroviral therapy, because again, you would like to reconstitute that immune system. The other thing to watch out for is that, if you have a really suppressed immune system, you have this illness that's coming on, and then all of a sudden I give you drugs that try to knock up that immune system, what do you think your immune system is going to start to do? Going to kick into overdrive, and it's going to actually make them more sick than they were to begin with, right? Because again, usually illness, when you have your immune system kick in, it's going to be febrile, or you're not going to feel very well. So that's one, this kind of immune reconstitution syndrome, they call it. And so it can happen, but again, it's one of those things where you have to kind of consider what's going to be the benefits versus the risk here. So in general, you'll start antiretroviral therapy at the same time you start therapy for the opportunistic infection. Just know compliance can be an issue because now they're starting off even more meds than they would be otherwise, and so it could be kind of an issue there for some patients. Okay, so the first one we'll talk about is PCP pneumonia, or Pneumocystic Jirovecii pneumonia. It used to be Pneumocystic carinii. That's why sometimes we'll still see it as PCP pneumonia, or you may see PJP, probably the more common name for that. And so basically, the fungus has kind of protozoal sort of characteristics. And have you guys covered any of this at all yet? Okay, good. So we covered some of it. Basically, it's pneumonia that will develop for these patients. I'm not going to get specifically into manifestations. We'll just talk about some examples and what we'll use to treat it. Basically, the treatment of choice for this is going to be sulfamethoxyl trimethoprim, or Bactrim. So we're going to do this, and again, typically because their immune system's not great, Because obviously they're showing us that they already have PCP pneumonia. We will treat them for a longer time period than you would otherwise, right? So you may need only 14 days of therapy for most patients. For something like this in the AIDS patient, 21 days at a minimum, right? So again, we're going to treat them for that. And then we can utilize prophylactic therapy. This is usually where we'll, if their CD4 count gets less than 200 for these patients, we'll start a prophylaxis with Bactrim. And then this dose is usually lower than what you would see if they had the actual disease. And so you may see them give Bactrim like 3 times weekly. We do this a lot for some of our cancer patients who are neutropenic. We'll actually give them Bactrim, say, Monday, Wednesday, Friday, and that will help to prevent PCP from occurring. Right? You have kind of low levels of the Bactrim around all the time, prevents the bacteria or the fungus from kind of kicking in. There's Candidiasis or Thrush. So again, most patients do not develop candidal infections on their own unless we have. You remember any drugs that cause you to develop candidal infections? Yeah, inhaled corticosteroids. Remember, we're using like Arflovin, things like that for asthma. Right, so this can happen in these patients. The problem with these patients, and again, for the asthmatic patient who develops thrush, usually it's going to be more of an inconvenience than anything. For these patients, however, they can become much more invasive. And again, invasive fungal infections are very difficult to treat, usually going to be in the ICU for several weeks, and it's very, very nasty to deal with. This is one where we can do things like fluconazole, diflucan, either use the IV or PO for potentially up to 21 days, depending on whether or not it was kind of an oral versus an esophageal sort of infection. And then what we can also do is prevention. We can do a nystatin oral liquid. So again, kind of going back to the chemotherapy, we did the same thing for those patients when they're neutropenic. You give them nystatin, they kind of swish and spit, and that way that would kind of prevent the or swish and swallow potentially, and that would deal with that infection. Remember, the benefit of nystatin is not absorbed systemically, so it would only kind of work topically in the back of the throat, and that's kind of it. So it kind of limits a lot of the side effects. And again, some of these you're going to find are not going to have specific recommendations as far as when to prophylax for. So this would be an example where there's no CD4 count recommendations. Just one of those things you may start up as they start to kind of get more progressive. If you notice any thrush, go ahead and treat it there at that point. Now on testing, I'm not going to ask you specifically, okay, the CD4 counts, 150, what do I need to prophylax against? But I may say, hey, patient needs prophylaxis for PCP, what are you going to use, right? And you say Bactrim, right? Or they have a thrush infection, what am I going to use? I'll have Bactrim, I'll have ritonavir, nystatin, and something else, right? And you'll know nystatin's a treatment for thrush, right? These are the things I'm going to be asking about. Other things you can see, and I'm not going to get into big detail on this, but certainly herpes zoster. This is something you might want to vaccinate for beforehand, if possible. Things like Mycobacterium avium complex or MAC, cytomegalovirus. So again, these are really nasty infections. You want to prevent this whenever possible, and the way you prevent that is antiretroviral therapy. Again, make sure they're on those regimens. Needs to at least be a 3-drug minimum, right? 2 NNRTIs plus 1 other class. These are things you need to remember for testing and for your patients, more importantly. Okay, so again, as I mentioned, patients are living longer. They're going to be more at risk for developing these complications, so diabetes, cardiovascular disease, hypertension. You can actually even develop long-standing HIV nephropathy, so you have this renal disease that occurs over time, and then even certain cancers they may be more at risk for. So those are things you want to screen for as well. And again, whenever you're adding on more drugs to treat their hypertension, their hyperlipidemia, look at the drug interactions, because I guarantee you, you're probably going to run into a 3A4 interaction when you use something that's not going to be 3A4 mediated. Okay. Okay, so any questions on HIV? It's a lot. Just getting used to kind of looking at the drugs and being able to fit in which category they go into. So if you see tenofovir, okay, that's an NNRTI. If I see raltegravir, I know it's an integrase inhibitor. Those are the kind of categorizations you're going to need to make to kind of be able to identify those regimens, whether or not it's appropriate. Okay? It looks scary, but it's not really that scary. It's just no good naming convention because most of them end with vir, and so it's not easy to kind of lump them into one big category. So unfortunate, but kind of the nature of the beast. Okay, so I'm gonna let you guys go now. So we'll finish this up next week. In addition, we'll try to hit some endocrine, and then the week after will be your test, right? Yes. So turn in your quiz by next week. The prescription assignment and your test will be due the following week, right? Remember, there's a prescription assignment. Yep. All right. Great. Any questions? We're on the same page. Yes, sir. I'm going to see what I can get to. I've not written the exam yet, but whatever we cover at the end of the material next week, whatever I cover, that'll be what's on the exam. Any other questions? All right. I will see you guys next time.